So today we will discuss two important topics, which are, one is the pharmacoeconomics and another is the pharmacogenomics. So these two parts basically comes under the general pharmacology, and these are slightly offbeat, but many questions come from this. Short notes as well as the viva will come from pharmacoeconomics and pharmacogenomics. So first, coming from the pharmacoeconomics. So until now, you will also get a class for the clinical trials. I will also take about this. So when a medicine have to come to the market, they have to undergo different types of the clinical trials. Okay. So first there will be preclinical trial that is done on the animals, and then the clinical trials are to be undergone, and there are different phases of the clinical trials. We will discuss this later, and there are some mandates for these clinical trials also. So after the clinical trial, the drug comes into the market, but there are different types of the drugs for the similar indications. So there may be some economic aspects of the drug usage also. So whenever a drug is to be chosen, for example, for any national program or for any disease, so we have to think not only about the effectiveness but also about the pharmacoeconomics. So what is whether it is economically suitable or beneficial for a large proportion of the patients or not. So all this encompasses a separate type of the subject that is known as the pharmacoeconomics, and there are different types of the analysis from which we can derive which drug is pharmacoeconomically better in comparison to the another drug. Okay. So let's start. Eta cholche? So first, characteristics of the formulary management. Formulary, you have also heard about the formulary. So there are the different types of the drugs that can be used for the treatment of a similar indications. So you know, you have, so for the pain, if there is pain, so there are different types of the pain killing medicines are there. For example, there is paracetamol is there. You will also read about the NSAIDs, that is the non-steroidal anti-inflammatory drugs. There are different other groups also. For example, you will read in the CNS chapters about the opioid analgesics. So there are different types of the drugs. So these all comes under the formulary. Now we have to choose drugs. One thing is about the individualized, whether the patient have different types of the comorbidities, whether the individual characteristics of the patients. Apart from this, there is efficacy, safety and tolerability. So some drugs are efficacious to one individual and not efficacious to another. Similarly, some drug is safe to one and not safe to another, and tolerability. Again, it differs from one individual to another individual. Some drug is tolerable to one and not tolerable to another. And apart from this, there is also humanistic outcomes that is usually calculated with the quality of life measures. For example, a patient with chronic obstructive pulmonary disease, that is also known as the COPD. So in case of the COPD, there will be dyspnea. Dyspnea means there is breathlessness that may happen, and some patients can have breathlessness with just some 2 or 3 walks, or some patients have breathlessness after 2 to 3 kilometers walk. So that is ultimately gives an impact on their quality of life. So in spite of having a disease, whether we are improving the quality of life of a patient, that is also important. Okay. So humanistic, this is the humanistic considerations. Mainly these humanistic considerations are important for chronic disease. Chronic disease means there is COPD, what I am taking, there is asthma, there is diabetes mellitus, hypertension. These are the chronic disease, whether you have to take the medications, in most of the cases lifelong, and with the medications your disease will be controlled, and then how your quality of life is more or less towards the normal, that is the very important thing. And of course the last is the cost consideration. So these are all the outcomes. So when we are treating a patient, we are not only just thinking about the drugs, whether the drug is affecting the disease or not, but we have to also consider these other outcomes also. So we have to evaluate the pharmacoeconomic evaluation when we need. It is an evaluation that considers both the effects and the cost of 2 or more alternative choices. So both the effects means whether there is any consequences as well as the outcomes as well as the cost. It is defined as this pharmacoeconomics, defined as the comparative analysis of alternative courses of action in terms of both of their cost and consequences. Okay. So we are comparing, for example, two modes of treatment or two drugs, not only in terms of its efficacy but also in terms of its economy or its cost consideration, and all of this analysis comes under the purview of the pharmacoeconomics. So these are the different types of the outcomes what we are just discussing, that may be the medical outcome, the end result of the medical care, that could be positive. Example, using the right antibiotic to treat an infection, and that could be negative, using the wrong antibiotic to treat an infection. Similarly, there may be some surrogate markers, that is a measurable unit that provides information regarding the outcome of interest. For example, if a patient has hypertension, ultimately if the hypertension is not treated, the patient may have heart attack, that is also known as the myocardial infarction. So if we are using a drug to treat the hypertension, basically we are using a drug so that the patient will not have an heart attack. So how we can measure that the patient, if we are giving this drug to 100 individual patients, how we are measuring this? We can measure this by means of surrogate marker. Here the surrogate marker is the blood pressure. So if the blood pressure is controlled by means of the different clinical trials, it has seen previously that if the blood pressure is controlled, the heart attack is also controlled. So these are the surrogate markers by which we can determine the end result of our outcomes. So this is medical outcomes. This is also known as the ECHO or ECO model, that is economic, humanistic and clinical. So clinical is similarly important like that of the economic as well as the humanistic. Humanistic means how we can improve the quality of life. So clinical outcomes, there may be either cure or comfort of survival. So there may be some drugs that can increase survival. For example, there is pancreatic cancer. You know, stage 4 pancreatic cancer, usually the survival period is approximately 6 months to 1 year. Okay. So there are some drugs are also that can increase the survival, for example, just 3 months or 4 months. So that there is also drug. That is the motto of that drug, that can increase the survival. Because the end result is death, we are just increasing the survival. Now we can compare this pharmacoeconomically whether this drug should be available as an essential drug to a large portion of population. For example, the drug is very costly and those patients who are having pancreatic cancer stage 4 are very less. If we are to avail this drug to all of our primary healthcare centers, the cost to the government will be very much more. So it is not pharmacoeconomic good. So is it clear now? So it is a very good drug to increase the survival for some months for pancreatic cancer. That may be good for the individual patient or the patient's relative, that his father or mother will live for 3 more months or 6 more months. But that is not pharmacoeconomically good for as a program or for the government. So like this. Humanistic outcomes, so quality of the life, different types of the quality of life, whether we can improve the physical function or emotional function, social function, role performance, means what is the role of that patient or person in the society. If the patient or person cannot fulfill his or her role, that will be a decreased quality of life. So whether we can give some drugs that can lead that person to fulfill his or her role in the society or not, that is also important. Pain and other symptoms such as nausea and vomiting. Pain is very common symptoms that may be associated with cancer. For example, many cancers we know that is incurable, but we are using some drugs to decrease the pain. So these drugs are mainly used for palliative purpose. So this is also the motto of that drug. Economic, whether an outcome expressed in terms of the cost or value of delivering care, expense, savings and cost avoidance. Whether what is the expense of that person, whether the person, if they are choosing another alternative, whether there is more savings or not, and whether we can avoid the extra cost. Cost avoidance means there may be some drugs that is very costly in day-to-day basis, but that drug can decrease the hospitalization of that patient. Okay, so if a patient getting hospitalized frequently, that leads to increased cost to the patient. So that is also should be taken into consideration. So these are the outcome methods what we are discussing. These are examples. For example, hypertension, indicator is the blood pressure. clinical outcomes is whether we can decrease the renal failure or stroke or myocardial infarction or death. Quality of life, we have to see whether we are improving or not. Economic outcomes, how we can measure whether the cost per unit millimeter of mercury decrease of blood pressure, cost per one stroke avoided, or cost per one life year saved. So these are the different economic analysis, for example. Similarly, hyperlipidemia means the LDL level or cholesterol level is very high. That may be associated with also myocardial infarction or stroke or death. Again, there are different types of the outcomes and different types of the parameters. Diabetes, very common. We are now the diabetes capital. So you can see diabetes, we can measure what is the blood glucose level, whether fasting or postprandial, what is the HbA1c. So from HbA1c, glycosylated hemoglobin, we can determine what is the control of the blood sugar in the last 2 to 3 months. So how the clinical outcomes, again the death or myocardial infarction, nephropathy, retinopathy, quality of life, whether the quality of life of that person is more or less normal. And again we can, economic outcomes can measure a cost per change in HbA1c, cost per some kidney outcomes or kidney transplant avoided, like this. Similarly, in case of asthma or COPD, we can measure this by forced expiratory volume or peak flow. So these are the different measures, so that we can see whether the patient have dyspnea or not, whether there is any exacerbation of that asthma or COPD, again any event or death, quality of life, and cost per symptom-free death. So this is just to give you an impression that not only the clinical outcomes but also humanistic and economic outcomes are also important when we are choosing a drug for a patient. Okay. So comparing the cost and consequences and outcomes of two or more alternatives. For example, this is the choice that can be involved the program A or program B, and cost A and cost B. Program means there are different types of the different types of the programs for the improving the health quality is going on in our country or in any countries. So we can compare this with the consequences, consequence A or B. So ultimately these are the types of evaluation in a nutshell. So we can see comparison of the two or more alternatives, whether it is done or not. So if there is no comparison is done and are both cost and consequences of the alternatives are examined, again it is no. Then whether we are examining only consequences, consequences mean whether we are examining only the outcomes, that is the outcome description, that is we are giving this drug, whether what are the outcome, how much it is decreasing the blood sugar or how much it is decreasing the blood pressure. If it examines only cost, that is the cost description. So we are not going into the details of the effectiveness or safety, we are just seeing what is the cost of this drug, what is the cost of this drug. Now if the cost and consequences of the alternatives are examined, it is examined, but comparison is not done, it is known as the cost outcome description. So this is the cost and this is the outcome. So we are not comparing, so this is only the description. Now we are comparing these two, and we are also examining the cost and consequences of both of these treatment or both of these programs. Then if it examines only the consequences, that is known as the clinical trial. If it examines only the cost, that is the cost analysis. And if it involves both the examining of the cost and consequences as well as the comparison, this is known as the full economic evaluation or full pharmacoeconomic evaluation. So these are different types of the analysis which is usually done when we are choosing a program, not only program. For example, in our Santiniketan Medical College, we are deciding that these are the patient profiles. Now we have to see what are the different types of the people comes in this area. So after this, we have to make a formulary for our pharmacy. So some drugs have to be continuously available in our pharmacy because these drugs are more in Santiniketan Medical College, but that drug may not be needed more in another medical college. So this pharmacoeconomic evaluation is needed for individual. For example, it can be done in a PHC level, in a hospital level, etc. So for full economic evaluation, there are 4 types of the full economic evaluation. One is the cost minimization evaluation, one is the cost effectiveness, cost utility, and cost benefit. What the units measured? The cost is usually measured in dollars or usually in rupees, and the outcomes are different. For example, in cost minimization, whether we are minimizing the cost just in terms of the monetary units. Cost effectiveness means whether we are comparing the cost with some natural units. Natural units means how much decrease of the HbA1c is done or how much millimeter of mercury hypertension is released. Cost utility is usually measured monetary units and the quality adjusted life years, meaning how their quality of life is improved or not. Cost benefit is again, it is done in both of the monetary units, both in the cost as well as the outcome. We will come to the details. First, coming to the cost minimization analysis. So, this is simple from the terms. So, cost minimization, how much there is difference of the cost between the two alternatives, two drugs or two programs, two methods, examines only the cost of competing technologies. It assumes equivalent effectiveness. For example, when we are choosing whether we are using a brand name medicines or the generic name medicines, here we are assuming that their effectiveness are same, but it is not such that is a different point. But we are assuming brand name medicine and generic name medicines both are equally effective. Now we are just seeing whether there is any cost minimization if we are using some generic drug or not. Similarly, two or more drugs in the same therapeutic class with similar side effect profiles, again we can compare. Net results is usually expressed as cost per patient treated. Okay. So, for example, these are the different diabetes medicines. These are in the dollar cost per month. So, you can see there is different, these are in the same groups. This comes under the sulfonylurea group of medicines that is used for the treatment of the diabetes. So, these are the cost. So, what is the difference of the cost between one to another? So, this is the cost minimization analysis. Next, coming to the cost effectiveness analysis. Now, the most important, this is the most important evaluation that is done as a pharmacoeconomic evaluation in day-to-day basis in different hospitals and different centers. So, cost effectiveness, here cost are measured in physical units and valued in monetary units, and effectiveness is measured in natural units of health improvement. That is, what is the clinical outcomes, that is the effectiveness. That is, what is the decrease of the HbA1c, how the hypertension is decreased, what are the years of added life, prevention of one event, prevention of one heart attack, like this. So, here the outcomes must be measured in the same units to compare the interventions. It can compare cost and reduction in HbA1c with cost and reduction in systolic blood pressure. So, it should be similar type of the effect in the two arms. This should be the similar types of the drugs used in the similar disease. Then we can analyze cost effectiveness of these two drugs. Like results are expressed like $100 per 1% reduction in HbA1c. So, HbA1c is measured in percentage. For example, in diabetes mellitus, the HbA1c is usually greater than 6.5% or 7%. So, when we are treating a diabetes mellitus, our aim is to decrease the HbA1c less than 6.5%. For example, one patient came whose HbA1c is 8%. Now, we are using one drug and again we are using another drug in another patient, again the HbA1c is 8%. Now, we are seeing after giving these two drugs, for example, for 3 months, how much decrease of the HbA1c is occurring. Now, we are calculating the cost. Now, we are giving the two drugs, cost of drug A and cost of drug B, and then we can calculate whether the 1% decrease of the HbA1c, what amount of the money is needed for drug A and drug B, then we can compare these two. So, again the similar thing example. So, incremental cost effective ratio, what I am just stating. So, this can be usually calculated from this. So, you can see this is total cost for drug A minus total cost of drug B, and then we can divide this by effectiveness of drug A minus effectiveness of drug B. Effectiveness means what I am just stating, how much it decreases the HbA1c, for example. So, from this we can achieve this ratio, incremental cost effectiveness ratio. So, from this we can calculate the different drugs in the same group, so that we can understand that whether one drug is cost effective to the another drug or not. Again the same thing, for example, drug A, the total cost for 100 patients are approximately $10,000 and effectiveness is 10 strokes prevented, and drug B total cost for 100 patients is $60,000 and effectiveness is 50 strokes prevented. Okay. So, we can calculate this. So, drug A, drug B total cost, strokes prevented. So, cost per stroke prevented for drug A is the $1,000 and drug B is the $1,200. So, you can see. So from this calculation we can see that there is $200 gap between this. So incremental analysis is the additional cost that one service or program imposes over another compared with the additional effects, benefits and utilities it delivers. So it is clear. So cost effectiveness is very important. Usually it is done when we are choosing two drugs. Cost effectiveness analysis, we are giving two drugs or two programs and we are seeing the outcomes, how much it is decreasing the HbA1c, how much it is decreasing the blood pressure, how much it is preventing one stroke, how much it is preventing one heart attack, like this. Now next coming to the third one is the cost benefit analysis. Here the resources consumed and health outcomes are measured in monetary units. Here both are measured in the monetary units. Okay. Decision rules choose the treatment with the highest net benefit. So we are basically here changing the benefits. For example, decreasing HbA1c, we are transforming this to a monetary units. That is, where if we are decreasing the HbA1c by 1%, what will be the monetary benefit to the patient? That means there will be a model, mathematical model. From this we can understand that if the HbA1c is not decreased, there may be more chances of the hospitalization, there may be more chances of the other drugs to be taken. So if there will be more HbA1c decrease, so these chances will be less. So this can also be transcribed to the monetary units and both of these are compared. So cost benefit analysis, here both of these, the numerator and denominator are usually compared with monetary units, whether in the cost effectiveness analysis, monetary units is the cost and the natural units, that is the units outcomes for the disease, are usually measured in the according to the disease. For example, for the diabetes the HbA1c, for the blood pressure there is systolic diastolic pressure, like expressed in two ways, benefits minus cost, whether there is net benefit or net cost, and benefit by cost ratio is usually also examined. So decision whether we will choose what drug we will choose, we have to accept programs with net benefit or benefit cost ratio greater than 1. That means the benefit will be more than cost, because both are expressed in monetary units. If it is greater than 1, that means beneficial aspects in monetary units is more than the cost in the monetary units. So benefit per cost, net benefits by net cost, and accept those programs where the ratio is greater than 1. So this is usually done for the large scale programs in the countries. Next, coming to the cost utility analysis. So we have seen the cost minimization analysis, cost effectiveness analysis, cost benefit analysis. Last, coming to the cost utility analysis. Here the resource consumed measured in monetary units and the health outcomes or consequences adjusted for life is used in the numerator. That is quality adjusted life year. This usually expresses the what is the quality of life of the patients. For example, if there is disability, the patient cannot go to the job, so there may be some loss of the wages. So this can also be calculated under the cost utility analysis. Okay. So utility is the value or worth placed on a level of health status or improvement in health status as measured by the preferences of individuals or society. So utility, so cost utility analysis. So if a patient is getting admitted multiple times in hospital, so there will be loss of wages, like this. So cost analysis framework, how it is done? First, study perspective is examined, then resources consumed are usually noted down, valuation of the resources is usually done, and then sensitivity analysis is done. This is all about the statistical analysis, details is not required. So to conclude, pharmacoeconomic analysis is basically a valuable tool to answer a clinical question, whether one drug or one treatment algorithm is cost effective to the another or not, and also the quality of life, whether if we were using one drug and another drug, whether it is improving the quality of life or not. And limitations, usually it is done different types of the statistical or mathematical modeling, but there are some limitations, like there may be some sensitivity analysis needed, applicability of the study data to individual patients. So there are always individualistic variation from one individual to another individual, that is usually not taken care of in this analysis, but this should also be taken care of. And some physician factors is also there, some physicians prefer one drug over another, so this can happen. So pharmacoeconomics can come as a short note, that is a very important, that can also be asked in the questions. Individually, cost effectiveness analysis is very important, that can also asked in the questions. So remember, pharmacoeconomics, you have to write what is the pharmacoeconomics, what is the utility of the pharmacoeconomics, why in spite of the efficacy and safety we are stressing upon the pharmacoeconomic analysis, and what are the different types of the pharmacoeconomic analysis. There are 4 main types of the pharmacoeconomic analysis: cost minimization approach, cost effectiveness approach, cost beneficial approach, as well as cost utility approach. So next, coming to the another topics, that is the pharmacogenomics. So again, you have seen in the pharmacokinetics and pharmacodynamics that there are absorption, distribution, metabolism, etc. In the pharmacodynamics, the drugs acts on the receptor, etc. But again, there will be individual variation. What I am stating this, and this individual variation may come from the genetic alterations. So you have also seen that some drug with the same disease can be beneficial for one person, that is not beneficial for another persons. So we are now moving towards more patient-centric approach, targeted approach, so that the side effects or adverse effects will be less and the effectiveness will be more. So this is the mainly the motto of the pharmacogenomics or the pharmacogenetics. So we are using the different drugs, and basically we are individualizing previously based on weight, sex and age, and we have to adjust the dose according to the patient's condition as well as what the patient is experiencing, that is whether there is any adverse effect or is there any comorbidities or not. But most of the time, recent times also, we are using one drug for one treatment. So but basically drugs presently available, one size fits all, but they don't work the same way for everyone. So with the years, there are more and more targeted drugs and targeted approach are coming. When we are reading the MBBS or the pharmacology, there are less targeted drugs, there are more targeted drugs. When you will be after 20 years, there will be more targeted approach. So more and more drugs that will not give a blanket treatment, that will be more individualistic, that is the goal, and that needs the help of the pharmacogenomics. So currently there is no simple way to determine whether people will respond well, badly or not at all at a medication. So that is the problem of different litigations also. If we are making this more individualistic, the litigations will be less. So you are going into the era where there will be more and more lawsuits with the patients and the doctors. And ultimately it comes that the patients are now viewing that this is a consumer, patients as a consumer, and they are seeing if we are giving a treatment as a drug, whether the drug is working or not. If the drug is not working, then whether the drug not working, that will be inexplicable, that cannot be explained always, because there is some genetics factors that ultimately leads whether the drug is effective or not. So that is the problem. And again, the adverse drug reactions. In the same drug can give the adverse drug reactions to one individual, in another individual there will be no adverse drug reactions. That is the problem. So different patients respond in different ways to the same medications. So when you have to write about what is the need for the pharmacogenomics, what is the main motto, so it has to be more individualistic, because the patient's response to the medication, whether in terms of the pharmacokinetics or the pharmacodynamics, is quite different from one individual to another individual. It cannot be a blanket therapy, it does not have to be a one size fits all. So the existence of the large population differences with small intra-patient variability is consistent with inheritance as a determinant of drug response. So it is estimated that genetics can account for 20 to 95% of the variability in drug disposition and effects. So you have read about the pharmacokinetics. So when we are taking a drug, how much amount of the drug is absorbed, how much drug is metabolized. So you have read about the cytochrome P450 enzymes. So you have also read about there are variation, genetic variation in the cytochrome P450 enzymes. So some drugs may be metabolized less, some drugs may be metabolized more. So numerous examples are there in which inter-individual differences in drug response are due to sequence variants in genes encoding either the drug metabolizing enzymes or drug transporter or drug targets. So all these are basically proteins. So when the receptors, the different types of enzymes, all these are the proteins, and there are the changes in the proteins, and with time also there are some mutations, minute mutations, polymorphisms, that also leads to change. So inherited determinants are generally remain stable throughout a person's lifestyle usually. So the way a person responds to a drug, this includes both the positive and negative reaction, is a complex trait that is influenced by many different genes. So there is not only one gene, different genes that helps in the different pharmacokinetics and the pharmacodynamics of the drugs. So without knowing all of the genes involved in drug response, it is difficult to predict a patient's response to a particular drug. So that is difficult. So we cannot know all the genes, so all the factors. Discovery of the people's genes, so small variations in their nucleotides. So there are some variations in the nucleotides what we can capture. So usually there are newer techniques are now available like DNA microarray technique, where there are some variations in the nucleotide sequence that can capture, and beforehand we can predict whether one drug can be beneficial for one person or that drug can give adverse effect to another person. So this is the progress towards the pharmacogenomics. So pharmacogenomics is a science that examines the inherited variations in genes. That is, these variations in genes are already inherited, and these variations are present in one cohort of the populations that is not present in another cohort of the populations, that dictate drug response. So whether the drug is responding good or worse, that is dictated by this, and explores the ways these variations can be used to predict. So basically we are making some predictions, prediction models, whether a patient will have a good response to a drug, a bad response to a drug, or no response to a drug. So these are the three options: good response, bad response, or no response. So whether we can predict more aptly, so that is the main target of the pharmacogenomics. So chromosomes, genes and DNA, we are not going into the details, you have already read in the first year. Chromosomes, genome, so nucleus of the human genome, approximately 30,000 to 40,000 genes, tightly coiled DNA is there, packet of coiled DNA. So these are the structures. Gene, you know about the gene, so very important. This is basically a code. Genes mean that contains the genetic code made up of pairs of the bases carries on the DNA molecule, and each chromosome carries a couple of thousand genes. And you also know, I think that 99.9% of your DNA is identical to everyone. So ultimately 0.1% is different from one individual to another, and that dictates a very large difference from drug response from one individual to another. So about the DNA, you all know about this, I am just skipping this. This is important, genetic polymorphism. So basically we are utilizing the genetic polymorphism to develop drug that will be more targeted. So these are the different forms of the DNA sequence. Poly means many, so many, and morph means form. So polymorphism are a type of genetic diversity within a population's gene pool. So usually it is seen that genetic polymorphism is done with one ethnic population to another. For example, in our South Asian population, there will be some genetic polymorphism is there that is quite different from a Mediterranean population. So that we can capture for a large cohort of the patients. So they can be used to map or locate genes. So genetic mapping, such as those causing a disease. So we can also capture that this can cause the disease, this genetic aberration, and they can help match two samples of the DNA to determine if they come from the same source. So we can detect this, whether this genetic polymorphism is present or not, by means of the different tests. So depending on its exact nature, a polymorphism may or may not affect the biological function. So some genetic polymorphism may be silent or non-clinical, that is of no clinical significance, but there are some important genetic polymorphisms what we can need. So what is polymorphism? It is a variation in the DNA that is too common to be due merely to new mutation. So some common mutations is continuously occurring, but here the variation occurs more than that. So a polymorphism must have a frequency of at least 1% in the population, 1% or more than 1%. So this genetic change, this base pair change is present in whole of the world more than 1%. Okay, so that is the genetic polymorphism. So then we can detect that some disease can be, we can examine this, that some disease can be more in those cohort of the patients, some drugs may be beneficial or not beneficial in those cohort of the patients. So this is the genetic polymorphism, more than 1% of the total population pool where that we can capture. So it is common in nature, related to biodiversity, genetic variation, adaptation, variety of the forms usually it retains and results from the basically evolutionary process, heritable, and is modified by the natural selection. So some genetic polymorphism ultimately goes out of this if it is not naturally selected. From the genetic polymorphism, next we are coming more specific. This is known as the single nucleotide polymorphism. So single nucleotide polymorphism or SNP, also known as SNP, is a small genetic change or variation that can occur within a person's DNA sequence. Here, these are the DNA sequence variation that occurs when a single nucleotide, either A, T, C or G in the genome sequence is altered. So single nucleotide, whether there is change in the A, T, C or G is present, again it occurs every 100 to 300 bases along the 3 billion base human genome, and again it has to be present more than 1% of the total genetic populations, total populations. So single nucleotide change that is easy to capture by means of the DNA microarray technique, that is present in more than 1% of the total population of the world, then we can capture. This is known as the single nucleotide polymorphism. Now genes influence response of the medications, already you have seen. So genes can determine how a person react to a medication. A genetic variation that makes the drug to stay in the body longer than normal or causing serious effects, or variation that makes the medication less potent. So all this can be captured by examining this single nucleotide polymorphism. Okay. So pharmacogenomics, it is the study of how an individual's genetic inheritance affects the body's response to drug. So genetic inheritance, mainly we are examining the single nucleotide polymorphism, how they are affecting the body's response to drugs. This is the main broad science, pharmacogenomics. Within the pharmacogenomics, there are different stages, like pharmacogenetics is also there. Here the term comes from the word pharmacology and genomics, and it is the intersection of the pharmaceutical and genomics. So it combines pharmaceutical science with knowledge of the genes, so genetics, proteins, proteomics is involved, single nucleotide polymorphism, that is usually done. Pharmacogenomics is the branch of pharmacology which deals with the influence of genetic variation on drug response in patients by correlating gene expression or single nucleotide polymorphism with a drug's efficacy or toxicity. So when we are identifying single nucleotide polymorphism, now it is usually examined whether some drugs are more effective or less effective, or giving more adverse effect or less adverse effect in those single nucleotide polymorphism or not. And by this examination indicates, so we have now a list of single nucleotide polymorphism and also drugs, so that we can see that this single nucleotide polymorphism and drugs will not be suitable or will be more suitable. So in those patients we can give this. So we are going to the era when we are doing some genetic test to some persons to see whether this type of single nucleotide polymorphism are present or not, and then we can choose our formulary whether this drug is to be given or not. So it is a new field that combines pharmacology and genomics. Ultimately the goal is the effective safe medication and doses that will be adjusted according to person's genetic makeup. So pharmacogenomics basically answers these questions. So why does a drug shows beneficial results in one and same drug as intolerable for others? Why does some need more the standard dose? So you can see some individuals need more drugs. The same drug will not give the effectiveness. Why does some need only half of the standard dose? Some needs less drug, less amount of the drug to see the same type of the effect. Why do some people get cancer, others don't? Why is cancer violent in one person compared to another? Why some drugs show more compliance? Again, the adverse effect. Compliance means the patient is adhered to the treatment. Patient is continuing to the treatment. Some patients cannot continue to the treatment due to the adverse effect. So it aims optimal drug therapy. Optimal drug therapy, that means the effectiveness will be highest and safety will be highest to ensure maximal efficacy, minimal adverse effect. It holds the promise that drugs might one day be as per each person's own genetic makeup. And it examines the same thing I am giving just because this is the important, inherited variations in genes. So examining the single nucleotide polymorphism, inherited variations in the genes that is present in more than 1% of the populations that dictate the drug response, explores the ways these variations can be used to predict, prediction model whether a patient will have a good response, bad response or no response at all. Pharmacogenomics is a broader term. Within this there is pharmacogenetics also. In some of the cases these two can be used interchangeably also. So basically pharmacogenetics refers to the study of inherited difference or variations in drug metabolism and response. Only the drug metabolism and response and whether there is any change from one individual to another individual is usually measured under the pharmacogenetics. Pharmacogenetics is a part of a broader heading pharmacogenomics. So this is arbitrary, the same thing. Difference in the sequence of the genes, usually we are measuring the polymorphism, single nucleotide polymorphism, drug and dose. So important example of importance of the selection of the drug and dose. Whether the drug and also the dose, what amount of the dose is needed for one individual to another. Gene variation and prediction of the drug response, these all done due to the single nucleotide polymorphism. Okay, the same thing. So DNA microarray technique. So this is important. You have probably read something about this in biochemistry. So DNA microarray technique is the new technique. From this there are some speculated, there are some pre-examined single nucleotide polymorphism list is there, whether we can give this DNA microarray technique to see whether these SNPs are present or not. This is an evolving technology to see presence of specific SNPs quickly and affordably. So the field of pharmacogenetics began the focus on the drug metabolism, transporter, drug distribution, absorption, distribution, excretion, everything. So from the drug absorption, distribution, metabolism, elimination, drug transporter, how the drug acts, drug targets, all these are basically affected by the pharmacogenomics and pharmacogenetics. So drug metabolism, you have read about this in the metabolism chapter. This is important. This can come at the cytochrome P450 short note can also come, and also in the pharmacogenomics you have also right. So there are difference in the cytochrome P450. So accordingly the metabolism of the drug is also different. So there are, for example, metabolized by one cytochrome 3A family. Some drugs are more metabolized, some drugs are less metabolized. There are different examples you can see. Drug metabolism, I am not going into the details. Drug transporter is also a protein. For example, the P glycoprotein. So you have also read about this P glycoprotein or ABCB1 gene. So there are different genes by which the transport of the drug from one place to another place is also affected. So for example, P glycoprotein is an energy dependent cellular efflux of the substrates occur. So there are different drugs like several anti-cancer drugs, different other drugs, in fact different viruses are also effluxed by this transporter. If this transporter is not present or if this transporter is not functional, so there will be change in the disposition of the drug or the disease. So benefits of the pharmacogenomics, the same thing. Ultimately we are giving the more targeted approach, powerful medicines, so maximizing therapeutic effects, decreases damage to nearby cells. So whenever we are using some drugs, there may be some damage to the nearby cells, so we are decreasing this by means of this. So rejection of the trial and error therapies also. So there are, if there is any serious disease, so we are giving some drugs, the drug will not work, and then we are just changing another drug. So there will be loss of the time for the serious disease. So if we can beforehand know that this drug will not be effective, we will not use that drug. We will give straight away to those drugs that is effective for that disease. So there will be rejection of the trial and error therapy, exact method and appropriate dose. So we can start with the appropriate dose. So we will not have to examine whether this drug will be beneficial or not. Specialized screening of the diseases can also be done by the DNA microarray techniques. Better vaccines are available because vaccines are the preventive medicines. So you will see that more and more vaccines are now available because the prevention is better than care. So it can also be available by means of the DNA microarray technique. Easier drug discovery. So beforehand we can see that these are the areas where this, due to the change of this, there is disease and we can target this. So we can beforehand develop a drug that can target that. So there will be easier drug discovery, the clinical trials period will be less, reduction of the healthcare cost will be less obviously. But there are barriers to pharmacogenomic progress because finding the gene variation. Even now there will be many genes, many SNPs that yet not been captured, but it is evolving, more and more SNPs are usually captured and more newer techniques of the DNA microarray are usually evolved. Application to help prediction of the exact dose of a particular drug to a particular patient. Most important application is to target therapy to a subset of the disease, to test viral genomics such as selecting treatment for the HIV based on the resistance and also antimicrobial resistance. The problems is there are some genetic disease, there are some antimicrobial resistance, there are some chronic disease that we can target by this pharmacogenomic approach. To a limited degree, today clinical trial researchers basically use genetic tests for variation in cytochrome P450 genes to screen and monitor patients. Now the cytochrome P450, we know many things about the cytochrome P450, just read about this is very important. So there are the different enzymes and you know that different enzymes metabolize different drugs and there is also variation pharmacogenomically so that this cytochrome may be less active or more active, and accordingly the drug there will be more adverse effect or less adverse effect. So to conclude, it is pharmacogenomics to give the better clinical diagnosis, fewer clinical failure, faster drug development and breakthrough medicines. It can reduce the deaths, hospitalization and adverse drug reactions. So thank you. So this is about the pharmacogenomics. So pharmacogenomics can come pharmacogenomics or pharmacogenetics. Both of these can be used interchangeably. This is very commonly asked as a short note. This is very commonly asked and it can also comes in the Viva. And pharmacoeconomics, again it can come, already I have seen, it can act as a short note. Individually cost effectiveness analysis can come as a short note.